Good evening, everyone. Now I am welcoming Dr. Batsal for the program proceeding.
Good evening, everyone. I'm Dr. Vatsal Thakral. So, welcome to the third module of NIGF of hysteroscopy. So, for this is on every third Wednesday of every month. For the third module today is on histoscopic management of Mullerian anomalies, for which we have our esteemed speakers, Dr. Isha Kriplani and Dr. Desh Deepak. For that, before that, I would like to welcome Dr. Ragini Agarwal, ma'am, who is the president of NIGF. Welcome, Ragini ma'am.
Thank you, Vatsal. Very good evening to one and all. This program, Sikshadeep, what we have launched under NIGF, is a focused educational activity, and we have thought of bringing two topics, which is really day in and day out work for a gynecologist. First is Sikshadeep Obstetrics, which will be running on the first Wednesday. Vice President Dr. Taru Chhaya is in charge of that program, and we are discussing one of the most common operation and considered villainous thing from the society is a cesarean section. And the second, we have chosen the hysteroscopy because whether you are able to do a laparoscopy or not, but every gynecologist should learn how to do a hysteroscopy because it is only you who need to see inside the uterus. And I am thankful to Dr. Parinder Bhardwaj, who is the committee chair of the endoscopy, taken this responsibility and doing it in a very dedicated and very precise way. I'm really thankful to you, Dr. Parinder, for that.
Thank you so much.
And we all know that we came with a big bang with the Dr. Osama Swaki, who is the master of hysteroscopy, a magician, and we enjoyed that thing. Friends, this module will go on. And along with that, I just want to say that NIGF is not mine, not somebody's, it is yours. Every gynecologist who is a part of North India OBGYN fraternity, it is their own association. Please join, become life member. It's only 3,000 rupees, and for the existing members it is only 2,000 rupees. And ask your more and more friends to join it and make it a powerful platform, and we will really going to reach a height of academic excellence, and we will translate into the good health of our women in the society. Thank you so much for being here, sharing your time with all of us. And any of you have any idea how to take an idea forward, you want to introduce something, some webinar, some course, please connect with us. Mr. Roshan Kumar is looking after everything, whole IT, whole support, website. Please post your phone number, link of the Razor Pay, and Dr. Ms. Sonika, who is the office secretary. Feel free to contact any of us anytime. Thank you so much. Over to you, Vatsal.
Thank you so much, ma'am. Now I would like to welcome Dr. Shada Jain, ma'am, who's the founder of NIGF. Welcome, Shada, ma'am.
Ma'am nahi is going.
I think ma'am has not joined. So I would like to now invite Dr. Farendra Bhardwaj, sir, who is the chairperson of endoscopy, to invite the experts and begin the workshop.
Thank you so much, Vatsal. And thank you so much, Ragini Madam and Shraddha Jain Ma'am. It's an honor that you have given this responsibility to us and Vatsal, and along with my whole team, we are really going well in this forum. Now, I would like to mention specifically our mentor of this program, Dr. Alka Kriplani Madam, who is who is continuously guiding me to conduct this program in a smoother and a coordinated way. So very thankful to you. And let me introduce you, Dr. Kriplani ma'am, who is an expert for this session as well. Madam is past Foxy president, everybody knows, mentor uh, of many gynecologists, and currently working in a Paras hospital as a director of OBGYN. Welcome, ma'am, to this forum. And our next expert for this webinar, uh, a very senior, dedicated gynec endoscopist, Dr. Punita Bharadwaj from Delhi. She is the unit in charge and robotic surgeon at Sir Gangaram Hospital, New Delhi. Uh, One of the daring hysteroscopic surgeon, I would say. Welcome, ma'am, to this forum. Thank you so much for joining us.
Thank you.
So now over to you, ma'am, and I request you to please invite our speaker, Dr. Isha Kriplani and Dr. Desh Deepak, sir, to start this proceeding. Thank you, ma'am. So,
Good
Roshan,
evening,
please.
everyone. Thank you, Dr. Bhardwaj, for inviting me for this amazing teaching webinar. I now invite Dr. Isha Kriplani, who's a consultant at Paras Hospital, Gurugram, and she's been awarded a lot of awards. She's been an active endoscopist and doing a lot of good work in the field of gynae endoscopy. Dr. Isha Kriplani. Uh, do we introduce him straight away or do we
रोशन जी,
introduce?
डॉक्टर ईशा वाली स्क्रीन पे पॉज कीजिए और डॉक्टर रोशन को डॉक्टर ईशा को शेयर करने का ऑप्शन दे दीजिए।
ऑन है सर, शेयर कर सकते हैं मैम। डॉक्टर ईसा आप शेयर कर सकते हैं स्क्रीन, पीपीटी अपना, शेयर अलाउड है। डॉक्टर ईसा
आई थिंक डॉक्टर ईशा का म्यूट हो रखा है।
अनम्यूट कर दी।
हाँ, अनम्यूट कर दिया। स्क्रीन शेयरिंग का ऑप्शन मुझे आ नहीं रहा है एक्चुअली।
नहीं मैम, आ रहा होगा। नीचे में टॉप शेयर के स्क्रीन का एक एरो बना हुआ होगा, वहां से आप शेयर।
हाँ,
सेंटर में
वहाँ
क्लिक
से
होगा ना।
एक सेकंड।
मैम सेंटर में स्क्रीन शेयर का एक ऑप्शन होगा आपको।
हाँ, मैं शेयर प्रेस कर रही हूँ। हाँ, आ गया। वो कुछ सिस्टम सेटिंग्स थी। आई एम सो सॉरी।
अब फुल
दिख रही है मेरी स्क्रीन?
स्क्रीन
यस मैम, यू आर विजिबल।
राइट।
आप फुल स्क्रीन कर लीजिए बस, दैट्स इट नाउ।
ओके ओके
Yes.
मैम।
Thank you so much for the very warm introduction, and I'm very happy to be here today evening to share and learn from all of the esteemed participants and my seniors. So today I'll be speaking on Robert's uterus, and I'll be discussing in brief the Mullerian duct development and its anomalies. So I'm Dr. Isha Kriplani from Paras Hospital, Gurugram. And to begin with, every fetus, female fetus, goes through development of the Mullerian ducts, which starts from around 6 weeks, with the Mullerian ducts passing ventrally and medially to the paramesonephric ducts, which are the Wolffian ducts, responsible for formation of the male genital tract as well as the kidneys and the ureters. So at week 7, these descend caudally and go and meet the urogenital sinus, followed by fusion. And this fusion happens from a caudal to a cephalic manner, resulting in the formation of the uterine tube. Now, the upper parts of the Mullerian ducts, they form the tubes, the fimbrial ends, the tubes, the cornua. The middle part forms the uterus, and the lower part forms the cervix and the upper part of the vagina. Where the Mullerian ducts go and meet the sinovaginal bulb, there is proliferation of the sinovaginal tube, resulting in formation of the vagina, where again resorption happens in a chordocephalic manner. Similarly, the uterine septum gets resorbed in a chordocephalic manner, and anomaly at any level can result in abnormalities of the Mullerian. I'm so sorry. I'm just going to. I think there is some problem with the slide. 1 second. Is my screen visible to everybody?
Yes, very much.
I'm so sorry. Yes, all right.
You are also visible.
So now I'll be coming to the discussion of Robert's uterus. So it was first described by Dr. Robert in 1970, and it entails an oblique uterine septum dividing the endometrial cavity asymmetrically with a non-communicating hemiuterus. So due to the outflow tract obstruction, there is formation of hematometra in the obstructed cavity, resulting in backflow leading to hematosalpinx and endometriosis. Three types of Robert's uterus have been described in literature. The first and the most common is the one with a large hematometra in the blind hemicavity, resulting in acute pelvic.
Sorry, we can't see your slides. Only you are visible.
I am sorry.
Madam, welcome.
हाय रागिनी, मैं बड़ी देर से आ पाई क्योंकि ये आ ही नहीं पा रही थी.
I will just share my screen again. I'm sorry.
Now visible, full.
Now visible.
Now we can see. Now we can
I'm
see.
so sorry for the confusion. 1 second. Right. So there are three types of Robert's uterus. The first one, which I've already described, is the most common, with the large hematometra in the blind hemicavity, resulting in acute pelvic pain. So young patients present with the complaint of dysmenorrhea, pelvic pain, cyclical abdominal pain. And here there is a collection in the non-communicating obstructed hemicavity. The second kind is one with inactive blind hemicavity without hematometra. So there is no endometrium in the non-communicating cavity, hence there is no collection of menstrual blood. And these patients usually present later, and the diagnosis is more difficult because it does not present with the typical clinical picture of a hematometra. And the third variant is a small hematometra in the blind hemicavity. Now, there are various classifications for Mullerian anomalies. The most commonly used are given by Eschrey or ASRM. Eschrey defines Robert's uterus as a complete septate uterus with unilateral cervical aplasia, being class U2B C3 V0, whereas ASRM simply defines it as a septate uterus as a class 5 anomaly. Now, coming to the organogenesis in embryology, how does the Robert's uterus come to be? So we just saw a video where I showed where the two Mullerian ducts, they fuse in a chordocephalic manner, and then the septum is resorbed in a chordocephalic manner. Now, in some patients, in some fetus, there is a segmental agenesis of the isthmus, and there is a presence of external indentation, or there is lack of resorption of the septum between the upper regions of the Mullerian ducts. Also, it has been proposed that there is unilateral cervical aplasia. So this is what causes the asymmetrical septum. Now, it has been given in literature that blind horns are more common on the right side, as the left Mullerian duct advances slightly ahead of the right. However, left Robert uterus has also been reported. Now, these patients present with progressive dysmenorrhea because of outflow tract obstruction and collection of menstrual blood in the obstructed cavity. This can result in chronic pelvic pain, infertility, as there is backflow of menstrual blood from the hemicavity to the tubes to the peritoneal cavity. It results in adhesions. It results in implantation of endometriotic glands in the peritoneal cavity. And there may be recurrent abortions because of the presence of a septum. And rarely, pregnancy in the non-communicating horn has also been reported. Now, secondary features due to obstruction such as hematometra, hematosalpinx, endometriosis are commonly seen in these patients. Now, what do we usually confuse a Robert's uterus with? So, mostly our radiologists give us the diagnosis of a non-communicating rudimentary horn. Now, this is where, the eyes do not see what the mind does not know come in, because there is not much awareness about Robert's uterus because it is a rare anomaly. Mostly the radiologists give a diagnosis of a rudimentary horn, and we end up excising the rudimentary horn, compromising the reproductive outcome of such a female. So how do we differentiate between a unicornuate uterus and a rudimentary horn? Unicornuate uterus and the Robert's uterus. In a Robert's uterus, the fundal contour will be normal because there is fusion of both the ducts and resorption has stopped at an initial level. So the fundal contour will be normal. It may be convex or flat because of the collection in the obstructed hemicavity, or it may have a small indentation of less than 1 centimeter. Also, there will be an external indentation. You can see the red arrow. So this is the area of the cervical agenesis. So there is an external indentation because probably half the cervix on the side of the Robert's uterus is not developed. Hence, there is a sharp curve over there. Whereas in a unicornuate uterus with a non-communicating rudimentary horn, there will be a fundal cleft greater than 1 centimeter. So here we have to remember there has not been proper fusion of the tubes. So the fundal contour is compromised. It will not be flat or normal. There will be a stronger, bigger indentation. So this is the clinching point of the diagnosis, because often in a Robert's uterus, the septum may be very thick, making the clinical diagnosis intraoperatively difficult. So we must fall back on the imaging to confirm. Also, sometimes Robert's uterus have been confused with a juvenile cystic adenomyosis or an ACUM, acute cavitating uterine mass. Now, ACUM, JC are completely different entities wherein the collection is in a localized area of the myometrium, and the final diagnosis is on histopathology, but there is no connection to the tube. There is no hemicavity. It is just a localized collection in the myometrium. So how do we diagnose a Robert's uterus? Imaging plays a very important role because intraoperative diagnosis is mostly a surprise. Hence, we should always check the imaging findings of a reported unicornuate rudimentary bicornuate uterus with a unicornuate obstructed cavity. 3D USG helps us in identifying the pathology. MRI is very useful in confirming diagnosis. Also, MRI is more reproducible. We can review the images in our OT. And ultimately, when we do concomitant hysteroscopy with laparoscopy, on laparoscopy, there is a uniform fundal contour. In hysteroscopy, only one ostia is visualized, only half the cavity is seen. That is what gives away the diagnosis that the other cavity is obstructed. So in the past, often when these cases were diagnosed intraoperatively as a surprise, the immediate resolution by the surgeons was excision of the obstructed cavity because they were not able to differentiate whether it is an obstructed, a non-communicating rudimentary horn or a Robert's uterus. So either by laparoscopy or laparotomy, more frequently laparotomy in the past, most of the case reports describe laparotomy followed by rudimentary horn excision was done, and this alters the anatomy of the uterus, cutting away half of the potential space of the uterus and thinning the myometrium at the site where the rudimentary horn is excised. Whereas now, with better understanding of the Robert's uterus, we know that we can unify both the horns, the non-communicating and the communicating cavity, by septal resection, hence giving the patient a normal volume of the uterine cavity and further optimizing her future fertility. So unification of the cavities can be done by hysteroscopic metroplasty, which can be ultrasound guided or more conveniently laparoscopy guided, so that we can have a clear vision of the laparoscopic view. Now, the benefit of laparoscopy is also in the same sitting, we can operate and treat the hematometra, the hematosalpinx, the endometriosis, the adhesions around the tubes. We can restore anatomy and give the patient a better fertility prognosis. Now, this is a video where the patient presented with the progressive cyclical pain followed by continuous pain throughout the month after 2-3 years of cyclical abdominal pain. She had a history of previous myomectomy and attempt of unification of uterine cavity done outside, which the attempt had failed. They had not been able to identify the septum and do the resection. So she presented to us, and initially there was very little connection in the non-communicating horn. It was on the left side. So we told the patient to come back after 3 months because we wanted some menstrual blood to get collected, as this collection in the obstructed horn, the bulge gives the surgeon an idea where to incise the septum, because the bulge guides during hysteroscopy. Okay, this is where the bulge is, so this is the area of the septum. Otherwise, in Robert's uterus with a small collection or no collection, it becomes very difficult to identify the cavity, as the septum can be very thick. So here in the MRI, we can see there is the right horn, which is the normal communicating horn from where the patient was getting her normal menses. Then there is the left non-communicating horn, which is obstructed with minimal collection inside. And under the non-communicating horn, there is abnormal looking fibrotic tissue. Now, this is again a very important point to be kept in mind. Under the side of the Robert's uterus, you will find some fibrotic tissue or acute indentation, which is suggestive of cervical agenesis on that side. So after reviewing the MRI films, we did a laparoscopy and a hysteroscopic septal resection. On laparoscopy, we can see there is a collection on the left side and unilateral deviation of the cervix. There were some adhesions around the tubes in the ovaries because of retrograde menstruation and endometriosis. So the adhesions are released meticulously to restore anatomy and give the patient a good fertility prognosis for the future. There was some infective blebs, which are commonly associated with endometriosis. These were removed, and the tubo-ovarian anatomy was restored. Following which hysteroscopy was done. And on hysteroscopy, we can see only one ostia is visualized, which is the right ostia. And as we come to the left, there is no cavity. It is a solid wall, which is the septum of the Robert's uterus. So again, after proper mapping of the uterine cavity and coming down to the level of the internal os, ensuring that it is not a bicornuate uterus, the septal resection was started from the fundal side. Here we are using a monopolar resectoscope. The distension media is glycine, and a Collins knife is being used to resect the septum. So slow, purposeful movements are made, identifying the region where the non-communicating cavity of the Robert's uterus may be present. As you can see, it is a very thick septum. Despite incising a good thickness of the septum, there is no bulge. There is no visualization of the opposite cavity. So this is how Robert's uterus is very tricky. And this is the reason why majority of the surgeons end up doing a rudimentary horn excision, because it takes longer to reach the non-communicating functional cavity because of very thick septum. And this thick septum causes more of retrograde menstruation, pushes the blood through the tubes into the abdominal cavity rather than letting it collect in the uterine cavity. So you can see we are going on incising, yet there is no visualization of the cavity. So again, as we come down here, you can see a lot of fibrotic tissue. You will see as we dissect. Just above the level of the internal os, here we are taking a panoramic view to ensure that we are at the correct level. And just above the internal os, there is a lot of fibrotic tissue present, which is presumably a remnant of the agenetic cervix on this side. Now, after we were not able to see any bulge despite sufficient incision of the septum, we decided to get innovative. A cyst aspiration needle was inserted laparoscopically just under the fallopian tube. I will just be showing the visual here. So the cyst aspiration needle is inserted just below the level of the insertion of the tube, and methylene blue dye was pushed through this cyst aspiration needle. And you can see as the cavity got distended, there is bulge of the septum at the area of maximal thinning. Also, there is some seepage of the methylene blue dye from the obstructed cavity into the communicating cavity. So this is what gave us an idea regarding the location of the cavity, because the functional cavity of the Robert's uterus is rather small. It is not a big cavity usually. So just to be able to pinpoint and identify the location of this cavity, here you can see a hole has been made in the septum from where the methylene blue is freely flowing into the communicating horn. And then Using this hole as the guide, we are just incising the septum medially and laterally to open up our view of the cavity so that we can visualize the ostia and resect remaining septum without damaging the ostia. So mostly these tubes are patent on the site of the Robert's uterus because there has been some hematometra, backflow, hematosalpinx, and the thick septum pushes the menstrual blood through the tubes back into the abdominal cavity. So taking care not to damage the ostia, not to damage the patency of the tube, and excising the entire thickness of the septum to ensure that there is no restenosis, there is no reopposition of the margins of the septum, and the patient does not end up having an obstructed hemicavity again. It is very important to excise this thick septum. Sometimes excision can also be done using, so this is the cyst aspiration needle that we used as the guide to insert methylene blue dye. And sometimes this thick septum can also be excised using a loop. So right now we are using a Collins knife, but even excision with a loop of such a thick fibrotic septum helps open up the normal endometrium of the side of the Robert's uterus. Here you can see how beautifully the entire endometrium has been exposed and the cavity has been unified. And we can even see the ostia of the side of the Robert's uterus. Now, after complete excision of the septum, the cyst aspiration needle was removed and unification was confirmed by taking a panoramic view. Remnant of the septum is being incised here at the level of the fundus. And by rotating and seeing the opposite ostia, ensuring that both the ostia are at the same level and the septum has been properly excised, the correction of this Robert's uterus was done. Tubal patency was also confirmed after the septal resection because patient was desirous of future fertility. And as you can see, despite having so much, blood collection and retrograde menstruation, the tube is freely patent. Endometriotic spot fulguration was done for the remaining endometriotic lesions. So this was, I'm so sorry. Is my screen visible?
Yes.
Yes.
Very much. But
So,
it is the back to zero initial view.
yes. So this was the management of a case of Robert's uterus with the non-communicating bone and collection, mild collection in the Robert's cavity. I'll be happy to take any questions.
May I ask question?
Sure, sir.
I have also operated 2 cases of the Robert uterus. Whether we can inject the methylene butyrate sonography guided also, that will also
Yes.
help. Then second thing, it depends upon the what type of the Robert uterus. Suppose if there's more collection in the non-communicated part, so it is easy to resect with hysteroscopy.
Absolutely.
But type 1 and 2, we can even resect, clear with laparoscopic approach also. My one patient of my Robert uterus even conceived with laparoscopic approach also. And because sometimes because of obstruction there is endometritis also. That
Yes,
part.
yes.
So that's I want to share, and very nice presentation.
Thank you.
Nice presentation, Isha. I want to ask one question. As you said, there's a lots of retrograde menstruation in your practice. Have you seen the endometriosis also in these patients?
Yes, ma'am. Frequently, patients with Robert's uterus have either ovarian endometriosis or peritoneal endometriosis. Frequently, there are adhesions between the tubes in the ovaries, and the tubo-ovarian anatomy is distorted.
Because the pain always will be confused with the endometriotic pain, not considering that.
So, endometriosis is a result of the obstruction.
Yeah.
Yeah, as soon as the obstruction is released, your endometriosis will settle down. And I
Yes.
think it's a very good trick of injecting methylene blue, provided you are an expert with laparoscopy. Like Dr. Saab said, that ultrasound guided can also be done.
Yes, ma'am.
Great presentation, yeah. And a good handling of Collins knife. I think it's a fantastic instrument. Only thing is that the vision, you have to turn the whole thing around to have a vision of the other side of the cavity. That's the drawback of Collins knife. And of
Yes.
course, Uh,
Uh,
Great presentation. Thank you.
it was a madam. It was a
Yes.
great presentation, and this technique of putting the methylene blue is really very interesting. Otherwise, when we do this much thick septum, we really we think that yes, we try to plan abandon, but you took a good decision and you are in a such a stage. Good presentation.
Thank
Thank
you,
you.
sir. Thank you.
It's Isha's original idea to put methylene blue. I was lost.
Can I ask something, ma'am?
Yes, sure.
Isha, I just wanted to ask you whether when you were resecting the septum, did you keep the laparoscope also inside? Were you, matlab, was it helping you that time?
Yes, so transillumination also comes in as an excellent tool while, such septal resections. We use transillumination almost constantly to identify where we are incising, how much thickness of the muscle is left, and in which direction to incise. So maybe in my next presentation, I will add a little clip where on transillumination, you can see the proper, deficit of the light in the area of the septum. Even in a normal septum, in a septate uterus, which is just, a simple vertical septum, you can use transillumination to guide.
What she means by transillumination is initially you will see the half cavity. In laparoscope, you remove the light source and make the abdomen dark. And once you cut the septum, the whole uterus, both sides become one and gets transilluminated, telling you that you have removed complete removal of septum has been ensured. Why don't you show that clip, Isha?
I don't have it right now. I will add it in future.
ईशा को तो फिर से बुला लेंगे, ईशा कहाँ पर है, फिर से आ जाए।
Arey, Ragini, I could not come initially, but I want to say something about Ragini to everyone. Ragini is the star. Ragini may not be doing that many cases, but she is doing great teaching for everybody in every aspect. May it be fetal medicine, may it be midlife, may it be endoscopy. I have become a big admirer of Dr. Ragini.
Madam, thank
She
you.
is the real teacher.
He was always a star, madam.
Thank you.
Always encouraging and guiding.
Not encouraging. She is tirelessly for decades. She has been, she started teaching in Gurgaon. She made a great society. I think that's the real teacher who will make people learn.
Yeah. True.
So we will
Very
move
truly
forward.
said, ma'am. She is great teacher. She guides us and let us work also along
We
with.
will move forward.
But
We'll move forward.
I shall be failing in my duty if I don't appreciate one or two more people. Farendra Bhardwaj, she was such a young chubby boy and वो तो अब बिल्कुल स्वान हो गया, इतना काम करता है. Bhardwaj, I have seen you growing, beta. Wonderful. And
Thank you
my
so much.
dearest friend, Dr. Nata, with whom I had the pleasure of dancing and is such a great dancer. Nata, your leadership is great.
We'll move.
And Farendra, you have lot more places to go because of the hard work you are putting in.
Madam, thank you so much. It means a lot to me. Thank you. So, ma'am, can we invite our next speaker, Dr. Deshmukh? Hello. Alka ma'am, can I request you to please invite our next speaker, Dr. Deshmukh sir, for the next session?
It's my absolute pleasure to invite Dr. Desh Deepak. These young boys now we are of the other generation. Jaipur people and Ragini is our own, and Farendra and all were students, and Nata was a very dear friend. I'm very sorry I don't have much interaction with Dr. Desh Deepak, but the way he asked the question to Isha, I could understand he is deep into laparoscopy. So it's a pleasure, Doc Saab, seeing you, meeting you, and the dice is yours.
Thank you, madam. Thank you, all the senior respected gynecologist. एंड मैडम आपके टीचर और मेरे टीचर शायद एक ही हैं, डॉक्टर एस सी सक्सेना. यू आर फ्रॉम रायपुर और बेसिकली आई एम फ्रॉम रीवा. So I
Okay.
am basically from did my PG from Riva, and my HOD at that time, Dr. S.T.
Can I
Saxena sir
say
was there.
something about डॉक्टर सक्सेना? उनकी जब ओपीडी चलती थी डॉक्टर साहब, तो वहां इतनी देर तक चलती थी रात को, कि पहले
Yes,
चाय
madam, I
वाला
know.
आके
हाँ
खड़ा
हाँ
हुआ,
हाँ.
फिर
Yeah.
गुब्बारे वाला आके खड़ा हुआ, फिर एक पूरी
तो
महफिल
मैडम
जम गई, मोहल्ला
आपके
जम
गुरु
गया।
मेरे गुरु थोड़ा कॉमन है, बहुत पुरानी बात है.
तो हम गुरु भाई बहन हुए।
Yes, madam. Thank you very much, Ragini madam, for providing me and Farin for providing me opportunity to speak on this platform. So my topic is non-obstructive and obstructive Mullerian anomalies. Both we try to cover as time is very limited. So many things are covered by my previous speaker. So I follow this classification, Israeli ESG classification. So I have taken the video of the U1 dysmorphic uterus, then U2 septate uterus, and then bicorporeal uterus also. And in that there is some septate cervix I have covered, and double cervix also with problem in the vaginal septa also. So I will try to cover all the videos as much as possible in the limited time. So I will not cover the basic things like organogenesis, fusion, already covered by my previous speaker. So where hysteroscopy work, if there is any problem in the fusion, whether it is vertical fusion or whether it is a lateral fusion, so there is role of the hysteroscopy to correct it. So, as far as clinical presentation is concerned, as we know, in cases of the septa, there is recurrent pregnancy losses, infertility, secondary infertility, and in obstructive Mullerian anomalies, always associated with dysmenorrhea, cyclical pelvic pain, vaginal discharge, and in some time, uterine rupture during pregnancy can also occur. So, it is very important to diagnose these Mullerian anomalies as early as possible. First, I will show my video of the lateral metroplasty. So, in what are the tips when we are doing the lateral metroplasty? Use sharp scissors, blunt scissor for radiosolesis. Use immobile blade of the scissor must penetrate the wall, side wall, and always estimate how much you want to correct, and orient in between, not always symmetrical. Avoid cutting the carnal ring area. Bleeding is not endpoint. So just simple video. Here we can see here that is a simple case of subseptate uterus. Here you can see there is jetting of the lateral wall. So, and the subseptate uterus is there. This patient was having recurrent pregnancy losses, but have seen that there is sufficient space also inside the uterine cavity. But you can see that carnal area is having deeper. So always before planning any cutting, do proper mapping also. And you can see I am working in the lateral wall of the left side. So you can see here this is isthmic portion. Then you can try to find out what is the fundal portion what is the body of the uterus. So you start cutting just above at the level of isthmus, and then first penetrate the fixed part of the scissor inside the lateral wall, and then give a small cut. So after cutting the left lateral wall, then always you can see here that I am cutting on the fundal portion. There is some subseptate uterus, so always see the ostia, where is the ostia, and then start cutting from one ostia to the other ostia for better safety, and always see the vascularity in between. You can reduce the pressure, then you can also see the vascularity. So you can see if you find vascularity, it means you are reaching up to the muscle layer of the uterus. Am I audible, madam?
रोशन जी
Then
Done. I'm muted.
हाँ, सबको म्यूट कीजिए.
here we are cutting the right lateral wall of the uterus. This is the again we should use the sharp scissor. You can see that fixed part of the scissor is penetrating the right lateral wall of the uterus, and then small cuts are made. So our aim is to see the ostia from the internal level, and we should correct the uterus. Suppose if it is Y-shaped uterus or a T-shaped uterus, our aim to make it V-shape. So our main aim is to increase the space in the uterine cavity simple using the sharp and blunt scissor. So in this cases, sharp scissor are better than the blunt scissors. So here you can see that this is the we are doing the lateral metroplasty using only sharp scissor, and our both hands should work in hysteroscopy. If you are cutting the, suppose in the right side, then you can use even the left hand also, and so that from, because in hysteroscopy in one hand you will focus the one wall of the uterus, so the lead will always be on the opposite side. So in the next video I will show you the both the pictures, how we should adjust our camera, how we can adjust our hands, so that we will not go in the wrong plane. So just in this video I was showing how to use the scissor while you are doing the lateral metroplasty and giving the fundal nick. So this is the final picture, and because in this case you have seen there is dipping indentation in the middle part of the uterus, so don't cut more on the middle part of mid part of the uterus. There is chances of the perforation. Always start from one ostia to the other ostia, and in these cases we are using the laparoscopic view also. So now there is another type of uterus. Sometime it is T-shaped uterus or it is Y-shaped uterus. So sometime we have to use the energy also, because where we are doing lateral metroplasty, sometimes there is tissue is very hard, so there is chances that you can break your scissor also. So now before starting you can see that we are able to see only black hole in the center and the cavity is very small. So just I am try to map that from where we should start. So always see what is the cervical level, then what is the ischemic level, what is the body level of the body, then you can start cutting. So you can see here that just I am just doing mapping before planning from where I should start cutting. So I am not able to see any hole in the ischemic part or in the cervical part. So only top you can see the black hole, so that is our marker. Then I have started cutting from this black hole to the left lateral wall of the this uterus. So slowly, even I am not able to negotiate this assembly inside the uterine cavity. So sometime we have to do the cervical shaving in some time in such cases. That is also controversial, but you can see after giving some cut I am able to negotiate inside the uterine cavity. So my cut always in the center between the anterior and posterior wall, and always we are using laparoscopic guidance also. So sometime for correcting the molar anomaly we are using two system, and suppose even glow sign previously was discussed, even glow sign also guide us. So you can see now I am able to see the one side of the ostia. So when I did the lateral metroplasty on the left lateral wall, now I am planning to do lateral metroplasty on the right lateral wall. So in this way we are increasing the space inside the uterine cavity. There was previously sonography, the space was just like a T-shaped uterus, we can say. So now it after you can see the energy is working very fast and very smoothly, and in such type of the cases our seizure will not work. So previously I tried with the seizure, but it was not working, so we have to use the energy. I'm using the Collins knife and using the glycine for distending the uterine cavity. So because I am trained in such a era that I am using mainly the monopolar current. So after a dysmorphic uterus, now I am going to cover the septate uterus. So we always I am not cover the embryological part. So everybody knows that there is chances of the recurrent abortions because of the septa, and there is 3D sonography is very important for diagnosing the arcuate uterus, septate uterus, bicornuate uterus, and even MRI will also help. So before planning any surgery, we should have proper measurement, proper planning. So you can see that depth from the interstitial line to the apex of the indentation is very important. If it is more than 1.55 centimeter, and angle of the indentation should be less than 90 degrees. And what is the definition of the biconvexity? Fundal indentation is more than 1 centimeter. So these are the findings of the 3D sonography. Then we can also plan the MRI in diagnosing the mullary anomalies where there is involvement of the cervix and vagina also. So there are so many recommendations that whether we should resect the septa or not to resect the septa, but there is guidelines also. But what is my opinion, if in symptomatic septa we should always resect it. Before planning the IVF we should also resect it. Suppose we are doing diagnostic laparoscopy, hysteroscopy, and we find the septa, then we should resect it. So now I am going to cover 3 types of the septa. One is the complete uterine septa. The second is thick and vascular uterine septa and cervical septa. And third one is the complete vaginal septa with complete uterine septa extending beyond the internal arch. So I will cover the 3 variety of the septa using the 3 different techniques. So now you can see here that light key. Okay. So now you can see the movement of my hand also. So here you can see that the light cable is directing towards the left side of the septa, and our using the scissor. So always start from the one ostia, and always this was not the complete septa, but it was more than 1.5 centimeter. So you can watch the hand movement also and the inside picture also. So here you can see that first I have started cutting the septa from the left side of the uterine cavity. So I am using my right hand, okay, and camera is from my left hand. So and keeping the cable directly so that we can focus on the ostia also in between, and in between we should come out and again see the level of the panoramic view of the uterus. So now you can see here that now when I will go towards the right carno, then I will work with the left hand. So you can see the outer picture also. The scissor is on my left hand and the camera is on my the right hand, and cable just focusing the ostia. So in this way you can able to do septal resection using both the hands. And how will you able to know that you have completed the septal resection? Once you find the bleeding vessels, pulsatile bleeding vessels, or you can see both the ostia at the from the level of internal os, or you can use the glow sign also. So these are the things that you can able to know that you have completed your job. So I have shown in this case how we can resect the septa. Sometimes under correction is better than over correction also. So you can just have the idea that you have created the sufficient space inside the uterine cavity, and you are able to see that you are having these, you can see the vessels pulsation. And after doing the septal resection, you can have some barrier also. We are using the pediatric Foley's catheter, and just cut the top of the catheter, and so that पहले air inject करके just cut the top of the, then inject inside the uterine cavity. Then according to size of the septa, you can put either 2.5 or 3 or 4 ml of the saline. And even some people are using gel also. So it is also better that it will prevent the further adhesion putting the gel. So now again this septa was bigger than the previous septa. I will just forward this video. So same technique, and so using the simple scissor also. So nothing is both are the same procedure using the simple cold scissor. So in cases of the infertility, try to resect the septa with only using the simple cold scissor. Suppose if the septa is very thick and vascular, and your scissor is not working, then we can use the Collins knife also for resection of the septa. So now you can see the vascularity also. The our process is complete, and even we can measure the distance. Suppose if we are opening our seizure, the seizure will open having up to 4 millimeter, and if you open the grasper, you can measure the distance. It will be 8 millimeter. So you can measure from the ostia also. So now the second case which I have taken is a thick and vascular uterine septa with cervical septa. So you can see here that it is U2 and C1. So in cases of if you are having fibrous septa inside the cervix, then you can cut this septa with scissor only. So I have cut this septa with scissor because inner septa was very thick. So before introducing our dissectoscope, it is very difficult. So in two cervix, there is no need of cutting, but in fibrous cervical septa, you can cut the septa. And after cutting the septa, I have seen that this septa was very vascular and thick. So there is concept that whether we should do the resection or we should excite the septa. So I have seen that and other surgeon like so in this case, I am showing you how if the septa is very thick and space occupying, then we can also excise the septa. So before excision, always try to map from where you should start doing the excision. So from one cavity, from one ostia to the another ostia, and these chips are very small, only 2 to 3 2 millimeter chips, and so there is further controversy, but Dr. Bitochi and Dr. Haresh Bagasia, they also one of the lecture that we can also thick septa can be also excised. And now the third case is a different case. In that case, there was complete two cervix, complete vaginal septa. You can see vaginal septa also, and two different cavities. So in such cases, either you can put a Foley's catheter inside one of the cavity and then enter to the first do the diagnostic hysteroscopy, see both the cavity, then you will see that this looks like a unicornate uterus. Then because the septa is very thick, so start cutting from first start the mock drill, like mock drill, just map it and then start just cutting just above the isthmus. So then you will reach to the another cavity. So I am working in the left side of the cavity and cutting the septa. So now you can see that we are able to see the another cavity. So we have make a fistula, then complete your septal dissection starting from the one ostia to the another ostia. So it will prevent the perforation also. Previously we are just pushing the Collins knife. Now we have started that when we are reaching near the fundus, so always orient yourself from one ostia to the another ostia. So in this way I have shown you the three variety of the septa using the three different techniques. So now this is again in the previous video I have shown you that I have not used the Foley's, but suppose in this case we have put, now you can see that this cavity just like looking like a unicornate uterus, there was very thick septa. So in this case we put pediatric Foley's catheter and nearly 6 ml of the normal saline in that bag, so that it will distend the another part of the cavity. So start now first you can see that I am mapping and doing diagnostic hysteroscopy. I'm going from one cervix to the another cavity. So before using Collins knife, first I have tried with the simple scissor also, but that scissor was not working. So now we have decided to cut this septa with the Collins knife. And why I am showing this video, because in that case I am using the pediatric Foley's catheter in one of the cavity, so it will also guide us. So now you can see I am working in the left cavity and going towards the right cavity. So now after making the any fistula hole, the saline will go to the another cavity. Now you are able to see the balloon. you are able to see the balloon. So now we are confirmed that we have gone to the another cavity. So now you can remove the Foley's catheter. Now you can see the Foley's catheter and then complete your septal section. So again, start from one ostia. So from lateral to the medial side, then from the now you are able to see the right ostia, and you can see that we are cutting from the right ostia, and then remaining part of the lower septa that was the in the body or in the stomach part is also cut. In after septal section, then again we can put the barrier. So now we have covered all the septa, and after covering all variety of the septa using the different energy sources, now this is the one of the septa which is present in the vagina. So this is known as oviara. Friend, we have done nearly 6 to 7 cases of the oviara in this region, and in different type of the oviara. So now, where is the role of the histoscopy? Those cases I am going to cover. So this is obstructive hemivagina with ipsilateral renal agenesis. That syndrome is also known as WW syndrome. So oviara syndrome is a rare Mullerian duct anomaly characterized by uterine didelphys, obstructed hemivagina, and unilateral renal agenesis. So I will not go much detail in the theory part. So we will go directly. So clinical manifestation in this case was very important because of the obstruction. These patients are having cyclical dysmenorrhea. Some patients are having infertility, and in such cases, sometimes there is pyosulpings. I have seen the cases where there was severe pyosulpings because some gynecologists, they are treating is like imperforated hymen, so they just did the needling if there is infection. And so there are two different variety of the oviara. So I will go directly to the videos. So in this case, you can see the laparoscopic view also. So in all cases of the oviara, we are doing histoscopy, laparoscopy simultaneously. So you can see the bulge. You can see the bulge here, and this is the looking like a bicorporeal uterus. So sometime first before doing the vaginal part, again always we do the diagnostic histoscopy, and in diagnostic histoscopy we always see that this is just like looking at unicornuate uterus. In unicornuate uterus you always see that there is single centrally placed ostia. So this is the diagnosis of the unicornuate uterus in histoscopy. So once you can see here that before planning the vaginal resection is very easy. First we can go to the both side and see the ostia. This is the cervical region, and now we are cutting this vaginal part of the septa with the resectoscope. So before cutting, we are just doing the mock and mapping from where to we should give the incision. So you can see here that the bulge is coming, and just cutting and making the fistula, there is mucopollulant discharges coming out. So because of this obstruction, sometime there is chances of the endometritis. So you can see that hematokalpas was not there, but mucopollulant discharge was coming, and even she was not having much endometriosis also in this case. But sometimes these oviara are associated with cervical agenesis also. In those cases, there is severe endometriosis also. So now you can see the vaginal part. You can see the vaginal part. We have cut the vaginal part, and this is the cervix. So and this is the remaining part of this septa. So what I'm telling in this, that we should get wide incision, so there is no chances of the further blockage. And in some cases we have to resect also. मतलब जो extra part है, then we should use the that loop of the resectoscope also. So now, because that resectoscope was not going inside the uterine cavity, you can see the endometritis and atrophic endometrium. So this is the part where there was a oblique vaginal septa. So I have just changed the my assembly. I'm using the now Vitochi histoscope and going inside the uterine cavity. There was cervical stenosis also. So we have corrected the cervical stenosis also. Now we went inside the uterine cavity, which was totally blocked. Now you can see that endometrium was totally atrophic. So this is the part we have corrected of the left side of the patient. So cases, already I have explained you, we are using two systems, histoscopy and laparoscopy simultaneously. So this is the correction of the OVRA using the resectoscope or using the histoscopic assembly. In another video of the OVRA, previously I did only this much part, but patient was not having any problem in the future. In few cases, I have to do the hemihysterectomy also, and in next case here, this is also case of the obstructive Mullerian anomalies. In this case, we have resected the remaining part of the septa also. So now this is the laparoscopic part. So you can see that there is no much endometriosis in such type of the cases. Now you can see here the bulge is from the right side. So this is the one of the cervix. Again we did the histoscopy using the Vitochi histoscope, 5 mm diameter, 2.9 millimeter telescope. So here you can see there is this ostia, and so again we have given the incision with the using the Collins knife, and again mucopollulant discharge is coming, and after this we used the loop of the resectoscope, and we have removed all part of the thick septa, vaginal septa, using the loop. So friends, where you want to correct any Mullerian anomalies, we should have proper team, proper mapping, and use two audio-visual system for the better safety. So here we are using the remaining part of the hanging septa. This is a very thick vaginal septa. बीच में लाइट जा रही है. Okay. So this is the one of the two cases of the OVRA, and even we can do it vaginally also. Some vaginal surgeon can also do it, but proper diagnosis is very important. So now comes the unicornuate uterus. So in unicornuate uterus, histoscopy is only for lateral metoplasty, and if it is a functioning heart, then we are correcting it with laparoscopy. So I'm just doing the creating some space. In all cases of the unicornuate uterus, do lateral metoplasty and try to do lateral metoplasty very safely, and you should always do lateral metoplasty where another horn is present. So these are the cases where we can correct using the seizure or using the different variety of the energy sources. So in conclusion, all cases of the obstructive and non-obstructive Mullerian anomalies, they are present sometime in early ages, like from puberty. Sometimes there is amenorrhea, dysmenorrhea, pelvic pain, recurrent vaginal discharges. That diagnosis is not certain, or there is concern for distal vaginal atresia. So, or sometimes there is transverse vaginal septa also. So always before planning any surgery, we should have proper mapping, proper team for better safety of the patient. Thank you very much.
Thank you so much, sir, for showing so many interesting cases. And
Any comment from the
any
expert?
questions for sir?
Yes,
Anyone would like
yes,
to?
I want to say something. Excellent presentation. Excellent presentation and documentation and visuals. I keep teaching that we should record and how much hard work you have to put in recording these cases, Dr. Desh. Wonderful.
Thank you, madam.
Amazing collection, Dr. Desh. Fantastic. I think you had the entire range there.
Madam, I have entire range of the Mullerian anomalies,
Yeah,
and
absolutely.
even in
And
this
no
small
wonder you were
region,
the
I have collection all Mullerian anomalies so far.
you're fortunate that you've been able to see so much of Roberts and Ovira and everything, all the range, because
Nearly 6 to 7 cases of the Oviara of the collection.
absolutely, yeah. No, not everybody is as lucky as you are. And of course, you've done a good job also at it. Uh, Tell me one thing, in a complete septa, do you incise from the internal os onwards, or do you leave the internal os level for a section? Because people talk
Madam,
about cervical incompetence.
Madam, I have shown one of the video that if there is fibrous cervical septa, then I have resected it. If the two cervices are there, then there is no need of the resection in that area. And if there is vaginal septa, if the patient is happy with their sexual life, there is no need of resecting when the vaginal septa also. And previously we are starting from the lower end using the seizure and just going up, like
Yeah,
pushing
that's
up.
another trick, because your Colin's
Another thing.
knife doesn't work when you are low down, very low
Yes,
down,
yes. So previously,
So
previously I was doing with Collins knife, pushing it,
yeah,
activating and pushing it. But
right.
when I reach up to the fundus, then I change it.
Yes.
So
So
because once you push near the मतलब fundus के बाद there is chances of perforation. So
yes,
then
exactly.
we should start from one ostia to the another ostia. You are right.
Absolutely. Now, yeah, that trick I wanted you
In
to
my
come
old
out with
videos,
that.
in my old
Yes.
videos, I am doing like that only. What you want
Yes.
to
The
say?
initial part with scissors, and then you switch to your
Yeah,
Colin's
yeah.
knife, and then
Or
fantastic work.
correction.
Wonderful.
Actually,
Thank you.
Mullerian abnormalities sometimes they are so fascinating, and sometimes they are so surprising also.
Yes.
What is surprising, Dr. Ragini?
I'll tell you, madam, one case. Very early in my career, almost 35, 36 years back, one patient came. She was with a missed abortion. When I tried to put that speculum, there was hardly speculum is able to go. Then what we found, there's a transverse septum at the 2/3 and 1/3, and there's a small hole. She got pregnant, but how I will do the DNC?
No, sperms are very small. Often they go
Sperms
through
are
that
small,
hole.
but our DNC is not small. Then we cut that septum, and the patient is not ready to understand that there was something. And I did that septum resection. And as sir has said, the Ochira, my first Ovira, she was from the Middle East, and she only came with a severe dyspareunia. When I wanted to do a PV examination, what it is, but that scene was really too much. इतना पेन उसने देखने ही नहीं दिया और एकदम कूद गई. So really, sometimes you people
Dr.
get
Ragini, I
experience.
had a patient of Oviera who even had a cesarean of an IAS senior official's wife. And she used to say, and she was not diagnosed even during cesarean. And she was referred to a psychiatrist and was getting so much of depressant and all these pain things. And ultimately, we have that lovely video. So eyes cannot see what the mind does not know. Previously, people were
Yes.
not having that good understanding. Nowadays, with MRI and good imaging, we are really far ahead in diagnosing
Yes.
and then managing these patients.
Really, things are changed. That's why, madam, what I am saying, in today's world, every gynecologist should be proficient in hysteroscopy and understanding these things. It is no excuse now that we are not able to do the hysteroscopy and all.
When we have started doing septal resection, there was no any diagnosis of the septa in the sonography. Sometime.
Unfortunately, Ragini, whosoever medals, we get lot of cases where that collection of blood, hematometer or hematocolpus, gets converted into pyometra and pyocolpus because some needling has been done. So
Yes.
they just needle and leave. That's very sad part of story doing halfway.
This
And
is
once
the
they
case of
have
the
that pus,
Sikshadeep.
then their fertility thing goes drastically down.
Yes, yes.
Madam, that's why we want this Sikshadeep. to teach these things from you masters, but
Sara
still I
credit
am able to
again you
think.
are taking, hai?
No, but I am seeing that
No,
only
you are
30
right.
people
You
has
are
joined.
absolutely
Only
right.
30 people has joined now. But wonderful, Dr. Deepak, and it's very nice to meet you.
Thank you, madam.
Yes.
From
So,
where Dr. Deepak is from which place?
Madam,
Kota.
Kota, Rajasthan.
And
Madam,
how many people have joined in?
Today,
Um,
madam, from
Huh?
50, now it is 30.
See, such a wonderful presentation, and there are very few people. Nowadays, there is so much of bombardment of knowledge that people are not coming forward.
Madam, can I say something about Dr. Deshdeepak?
Yes.
Sure.
Madam, he is one of the very senior person in Rajasthan who is performing minimal invasive surgery, and that too in not a very well developed area, which is Kota.
Why do you say
And
Kota is so well developed? It's churning out
madam,
so many.
way back. He's Dr. Deshdeepak. आप
I
कब
was in
थे?
Daud Bhatta,
94.
small place.
94?
Excellent meeting you, doctor.
95.
95 से he is in Kota, madam, and performing all these minimal access surgeries there. And second thing is, Dr. Deshdeepak, मैं आपसे पूछना चाहता हूँ, how do you calibrate your cavity enhancement in unicornuate uterus? कितना आपको काटना है, कितने आप enhancement तो नहीं हो जाएगा? How do you calibrate your surgery intraoperatively?
In my lecture, I have shown you the calibration. Like suppose double action jaw using the if you open this by forceps, then it will be 8 millimeter, right? So just go inside and measure it. So suppose and try to make it like a V cavity. So we can measure it with that biopsy forceps and seizure also. Seizure will, if you open the seizure, it will 4 millimeter. So by these instruments, we can just calibrate and measure.
Can I make a comment here?
Yes, madam. I
Your
wanted you to make
imaging really helps you. You see the thickness of that wall because not every unicornuate uterus you will be able to enlarge it. So if there
Yes.
is lot of fibrosis, then you cut and you always leave 1.5 centimeter. Otherwise, there will be rupture in next pregnancy. So your imaging helps a lot in mapping.
Yes, ma'am.
in plan. Yes.
And I
Sir,
also
can I
want
ask?
to say one thing for Dr. Deshdeepak, very humble, down to earth person, very knowledgeable, always helpful. I've seen him for so many years, very helpful.
Thank you.
Thank you, madam. Thank you so much.
Sir, can I also ask something? Sir, first of all, excellent talk, sir. And I think there would not be any gynecologist in Rajasthan who doesn't know, sir. And he has been doing excellent work. Sir, I just wanted to ask you that how do you determine the end point while we are resecting the cervical fibrotic tissue?
Cervical fibrotic tissue. Cervical fibrotic tissue, to the simple fibrous tissue, to just I will cut it with scissor, and then I went inside. In that case where there is no communication, like you want to say, na?
No, she wants to know what
What is
extent you exercise. It's very simple,
okay?
Dr. Meenal. You can, whenever you run your Collins knife or resectoscope, fibrous tissue has a different feel. And the moment you go to normal uterine musculature, it's very different feel and look. So it is clinician's assessment.
Okay, ma'am. Thank you.
Doctor, excellent discussion today. Dr. Farinder?
Ji, ma'am, we can.
Ah.
Dr. Sudha, madam, is there?
No, she is not there.
So,
Ravi,
on behalf
bhaiya
of
ko bula lo.
committee, I would like to thank Dr. Ragini madam, Dr. Shraddha Jain madam, Alka Kaplani madam, Punita madam, Dr. Tarusha madam, and all the office bearers of NIGF for giving us this opportunity. I would like to thank our speakers, Dr. Isha Kriplani and Dr. Deshdeepak sir, for this excellent presentation, and team of IT team, Dr. Mr. Rushan, Sonika ji, and our lovable Vatsal
Laga de.
for managing and coordinating all these things. Thank you so
And
much
our
for all your
experts,
guidance.
Dr. Punita and Dr. Alka.
Yes, Dr. Punita and Dr. Alka, of course. Thank you so much, everyone. And we are conducting every third Wednesday of every month, this hysteroscopy webinar. So please stay with us for the next webinar as well, and we'll update you about the next webinar and schedule at the speakers. Thank you so much.
Sure. Thank you. Thanks a lot for having us.
Thank you.
So much for joining
Quite
us.
in time.
Thank
Very
you.
nice
Thank you,
videos.
everyone. We will meet again.
Okay. Should I close the meeting?
Please, Rishant. Thank you so much.
Thank you, sir. Thank you.